We, along with probably most Americans, want waste, abuse, and fraud to be eliminated from our government, but we don't want to throw the baby out with the bathwater. And medical research funding is something that historically has had bipartisan support. There's an economic argument to be made about the impact of these funds in the local community, as well as the long-term benefits to Americans.
In this video, CancerNetwork spoke with kidney oncologists Wayne A. Marasco of Dana-Farber Cancer Institute and Thomas Powles of Bart's Cancer Institute, as well as president of KidneyCan, Bryan Lewis, at the 2025 Kidney Cancer Research Summit.
Solid tumors are complicated. They're not like liquid tumors like leukemia. Solid tumors are heterogeneous, so there's more than one type. There's always more than one type. There's safety issues because when you try to target them, they express molecules on their surface that are found in healthy tissues. So you've got to be careful you don't have what we call on-target, off-tumor toxicity. And thirdly, most importantly, is what we call tumor microenvironment. Those tumor cells commandeer the immune system. And even though you can find tumors with white blood cells, immune cells surrounding it, the tumor has sent out signals and decoys to stop the immune system from working and killing it. Well, I think we need to find a therapy that works, right? So none of the ones aforementioned have made it to the headlines or have investigators and clinicians saying this is a win. So there's still investigative work that has to be done. So in my opinion, there's two steps to this. One, finding something that works, and two, decreasing the costs. When we find the appropriate CAR T-cell therapy, the next step would be to, again, with further research that we're working on, to try to reduce the costs by delivering it in a different way. Same product, but a different method of delivery where you don't have to take cells out. You direct the therapy directly into the patient, where CAR T cells are made in vivo in the patient themselves, and then you can go to work without having to take them out of the body, what we call transduce them, expand them, all the safety and issues that go with it, and then put them back.
LIGHTSPARK-005 is a big randomized phase 3 study. It tests belzutifan versus everolimus in heavily treated patients with clear cell renal cancer. In the randomized phase 3, it was compared to everolimus in heavily treated patients. We showed high response, better PFS. We didn't show an overall survival advantage. We showed that distinct toxicity profile I talked about, and we also showed better overall quality of life. In this twist analysis we performed here, what we're looking at is time that the patients have without progression and without significant toxicity. That's essentially what it is, because progression-free survival just looks at progression and looks at the area of patients that are progression-free, which is great. But if all of that time was spent with significant toxicity, that obviously means less than if a patient has the same amount of time without progression with no toxicity. In twist analysis, Q-twist analysis specifically, we look at that time, that period, that area without progression and without toxicity. And then we bring in the quality of life questionnaires to work out what, in terms of that area, what the quality of life is during that period of time. And that's the Q of Q-twist. I think the story behind belzutifan so far is it's an agent which has been developed in two areas, which are very contrasting each other. Number one is VHL-driven disease, and that disease fork has shown that renal tumours can be put into a remission and a regression associated with belzutifan, preventing surgery on primary renal tumours. That's really important for patients. And then, of course, in the other extreme, in metastatic clear cell renal cancer, we go all the way where it's been developed very late, third or fourth line in many cases. Those two are very different from each other. The development of the disease, the VHL disease, and how that relates to very heavily pre-treated patients is quite complicated. It's probable, or even likely, that if we use belzutifan earlier in the disease process, it will work better. What we've shown with this Q-twist analysis is not only is it more active than everolimus, but it appears to be, from a quality of life perspective and a time-dependent quality of life analysis, to be better tolerated, making it attractive. The story for belzutifan is a long one, and looking forward into the future, there are a number of randomized trials. There's an adjuvant study. As I said before, I think that it might work better earlier in the disease. So pembrolizumab plus or minus belzutifan in high-risk post-surgery patients, number one. It's in the front-line setting, lenvatinib pembrolizumab versus lenvatinib pembrolizumab and belzutifan. So that's taking it into the front-line combination. It's also in randomized phase 3s in patients who have received one prior therapy, essentially second-line treatment, which is lenvatinib plus belzutifan versus cabozantinib. So a plethora of randomized trials earlier in the disease, big randomized studies. So belzutifan has a promising future, and of course, because it's well tolerated, it makes it an attractive combination partner.
KidneyCan was built around these patients coming together and realizing we needed a voice for kidney cancer and a voice in Washington. And that's what our efforts have been over the last going on 7 years now. And we've done over 2,000 Hill visits over the years. We have a spring and fall advocacy days effort where we both fly in and do a virtual component. When word came down in March about the CR being extended through the year, locking any funding and or cutting any future funding, KidneyCan mobilized. We were built for something like this, and so we fortunately were able to reach out to our grassroots community, both primarily online but also in person, and start what we're calling the Restore the Research funding campaign. And we've done that through sort of a variety of online and digital tools. We, along with probably most Americans, want waste, abuse, and fraud to be eliminated from our government, but we don't want to throw the baby out with the bathwater. And medical research funding is something that historically has had bipartisan support. I think both there's an economic argument to be made about the impact of these funds in the local community, as well as the long-term benefits to Americans and our military, as well as the health and the savings that can take place from finding cures now to avoid medical bills later. So. Major barrier is we don't have enough experienced cancer centers in every state. We do have a number of them across the country, but we're a big country, and especially out west, the catchment areas for some of these hospitals is huge, and the travel distance for treatment is hundreds of miles and maybe days off from work, especially if you're going for repeat treatment. So that's a geographical, rural, urban challenge for access. There's a whole nother layer of demographics of your income, your education, what you've learned, what you can learn about when you're diagnosed. And so getting to an academic center or some kind of NCI or NCCN accredited academic center that focuses on kidney cancer is a major effort that we undertake to try to educate patients about.